The most common troubleshooting I have to do for epidurals by far is honestly patient education and just trying to figure out where the pain is coming from. That dictates how we manage it. I've personally found that if the patient gets a really good discussion before we place the epidural and after we place the epidural when we're hooking them up to the pump, and explain to them how the epidural works and teach them how to manage it, people do really well, and they typically are able to self-manage with just their PCEA pump on their own, and we often don't need extra doses, or if we do, maybe it's just like one as we get closer to delivery. I find that when patients are not well educated on how to use the epidural, like the person who placed the epidural was maybe too busy or just didn't take the time to really properly explain how to self-manage or what to expect, that is when we run into issues with like, I don't know what's going on in my body, I feel too numb, I don't feel numb enough, I'm not sure how to handle this. And then we end up in this situation where I'm trying to guess what's going on or figure out what's going on from a person who's already in pain, already uncomfortable. They're feeling overwhelmed, they're feeling scared, and they don't really know what to ask for. And it's hard to figure out with each other what the situation is. So a couple tips for providers if you're learning how to manage labor pain with laboring epidurals is first and foremost, again, setting expectations. I like to tell patients that the goal for you with the epidural is to control your pain, but we don't want you to be 100% numb when it's time to push the baby out, because you need to feel enough pressure with contractions so you understand how to push and how to time pushing, and that's going to make it easier for you to deliver your baby. That being said, if you are completely numb, like if you accidentally use your button too much, make yourself too numb, it is still possible to push. Like the nurses can tell you when to push and how to push, but it's going to be easier for your mind-muscle connection if you have a little bit of feeling and a little bit of sensation. So the goal is for you to feel the pressure, understand what's happening, but we want it to be comfortable for you and manageable. And that is determined by the patient. Whatever feels comfortable for you, it's going to be different for everyone. Most places will set up their epidural pump with an automatic amount that gets dosed every 45 minutes or every hour, every 30 minutes. There's going to be some sort of a frequent dosing interval, and then the patient can hit extra doses as needed with like a lockout so you don't overdo it. Your needs might change as labor progresses. So if you're hitting your button a lot and it's just not cutting it for you, call us back early. That way we can give you extra medication to spread the local anesthesia further in the epidural space. That's how it works, right? It's not so much the concentration of the local anesthetic that we give, it's more about spreading the volume. I like to explain that there's a pool of local anesthesia being deposited around the epidural catheter tip. That pool of local anesthesia is responsible for bathing the nerve roots that come off your spinal cord, and that create sensation to your abdomen and your sacrum and all of the nerves that are involved in labor pain. So as you progress in labor, you might need new nerve roots covered when you're in a new stage of labor than what you needed earlier on in labor. So go ahead and hit that button as often as you need to. It takes 10 to 15 minutes to get real peak effect every single time you hit it. You can't overdose yourself. There's a lockout. The dose, the concentration of local anesthesia we give is extremely dilute. It's extremely safe. Worst case scenario, you make yourself too numb, you take a break from the button, it's gonna wear back off. If for some reason we're giving extra doses like top offs and it's not cutting it, it's really time to assess the dermatome level. I really encourage you to go ahead. I take like a glove and fill it up with some ice and tie a little knot in it, and I start to test with ice their level and see how far the block has come up to. If their level is just really low, they typically just need more volume. You might need to give more top offs. If they have a good level and they have like a hot spot or pain control is much better on one side than another, well, you run into more complex troubleshooting options. You can give a denser anesthetic. You can try more volume again. You could try repositioning the patient so that the side that is in pain is down and the side that's more numb is up. You can try adding extra things to your epidural, like clonidine or fentanyl, for example. Totally safe for mom, totally safe for baby. But I caution you with this because giving fentanyl and clonidine can actually mask a poorly working epidural, because the patient is going to get more comfortable quickly. If you need to use that epidural for a C-section for any reason, especially if this is a patient who's been in labor for a really long time, it's their first baby, like labor's stalling out, maybe the tracing is not that great on the fetal heart rate monitor, you can get into a situation where you dose up the epidural for a C-section and now you don't have a good enough block to keep mom comfortable for the procedure. So if you have any doubts about your epidural, you really should test it with some lidocaine. I always warn the patient, like, hey, your legs might get really numb and heavy, but it's important that we test to make sure your epidural is truly working, and this will get your pain under control if it's working, and the numbness will wear off. If you try lidocaine or lidocaine bupivacaine mixture and it's just not working for you, it is just time to replace the epidural. Do not keep giving top-offs endlessly and keep trying to troubleshoot endlessly and pulling the catheter back a centimeter and flushing and doing this, like trying a million different rescue maneuvers all night long. Your patient's going to be in pain, uncomfortable, they're going to be stressed out, and God forbid, if you have to go for an emergency C-section, it's not going to work for you. So depending on the situation, I usually give it like 3 shots, check level, volume. If that doesn't work, depending on what the level tells me or the nature of the pain, that tells us how to go from there. If the patient's feeling a lot of vaginal pressure and a lot of rectal pressure, they feel like they have to poop, I usually call in the OBGYN team to look at the patient and see if it's time to deliver. Sometimes your patient is just ready to push the baby out, and no amount of epidural medication is going to take away that pressure sensation. If they're having like back labor or some sort of a spot that's just like super uncomfortable that the epidural really can't cover, sometimes people have referred pain to weird areas, that is when I'm more likely to give some epidural, fentanyl, or clonidine. Last night I ran into 2 situations where an epidural was in for like over 24 hours and it just eventually stopped working. The patient was just in labor forever, and we don't have a good explanation for why it happens sometimes, but it just does. Both times I tested with a lidocaine bupivacaine mixture. Both times it partially worked. I told the patient, I think the best option for controlling your pain is just to replace the epidural right now. And both times I was able to replace it very quickly, and their pain was under control almost immediately, and they were so glad we did it. That's the long and short of epidural management. This is not medical advice. I can't tell you to go and apply this to every single patient that you see. Every single patient's different, every single scenario is different, but this is like a general idea of some ways you can manage laboring epidurals. By the way, you can also do preservative-free Precedex instead of clonidine. There are a few small studies on it. Some small studies show there could be a slightly increased risk of fetal bradycardia with the Precedex, so I haven't switched my practice to that, and we're not doing that currently in our institution, but the data does look promising so far. Clonidine has a longer history of being used in obstetric anesthesia, and because it does not have the same associated risk of bradycardia, that is currently my personal preference. Let me know what questions you have.